Today we're going to be discussing surgical site infection, which is why I'm here, and how we can find a potential solution to what is quite a complex problem. This seminar is supported by SSI, and at any time during the seminar, if you have questions, you can submit them by commenting on this video, and I will do my very best to answer as many of them at the end as they come through to me. What we are going to cover is understanding why surgical site infection is a concern, the impact that it has on patients and on the NHS as a whole, to begin to cover how and why they may develop, what strategies we can implement to help reduce rates of surgical site infection, and how we can use evidence-based practice to change our current working practice, and look at some of the things that we've been doing in my department, particularly using post-operative dressings to reduce surgical site infection. So first things first, what is a surgical site infection? It sounds like a really simple question, but it's not necessarily. It's an infection that occurs after an operation and is in the area in which an operation took place. It can be a little bit of discharge, a little bit of redness around a wound, right the way through to a life-threatening post-operative complication. You can classify it as a superficial infection that only involves the top layers of skin, or it can track all the way down into a deep organ cavity and involve tissues, organs, or implanted material if we as surgeons have left material in the body. Most surgical site infections are caused by contamination of an operative incision with microorganisms that are already on the patient's body before they go to theatre. We conduct around 11 million procedures in the UK every year, and it's estimated, and figures do vary, that there are around 200,000 surgical site infections every year. They are the second most common healthcare acquired infection, and account for about 20% of hospital acquired infections. To treat an infection, to treat a surgical site infection, first you have to define them. And we define them as one of three. They're either superficial incisional, deep incisional, or an organ space infection. A superficial incisional surgical site infection occurs within 30 days of a procedure and involves only the skin or the subcutaneous tissue. And it can be identified in a wound that has at least one of pus, a positive microbiological swab, or this has come from the CDC, so the Americans, an incision that's deliberately opened by an attending physician, so a surgeon or a surgical doctor. And the patient also has increased pain or a tender wound, localized swelling, redness or heat to that wound. Now, this definition doesn't include cellulitis of the limb in general, or a pin or a stitch site abscess. A deep incisional SSI is below the level of the skin, so it might involve fascia or the muscle layers below it. And again, the patient will have either pus coming from that deep incision or an incision that opens, so that might open by itself in what we call dehiscence, or it might be opened by a surgeon if they go back to theatre or on the ward at the bedside. And it does need, again, a positive microbiological culture. Patients should also have fever, and again will have local pain or tenderness. An organ space surgical site infection is an infection within 30 days or 90 days where there's implanted material of your operation, and the infection is deeper than fascia or muscle. This is normally intra-abdominal or intrathoracic. They will have pus coming out of a drain. Again, organisms seen on aseptically obtained fluid or a tissue sample, or they may have an abscess that's seen on imaging such as CT or ultrasound. Patients that get an SSI, a surgical site infection, are 5 times more likely to be readmitted to hospital after they've been discharged. They're 60% more likely to spend time in intensive care, and they are twice as likely to die than those who don't have an infection after their operation. Again, figures vary, but the current best estimate is that it costs the NHS somewhere about somewhere between £2,000 and £10,000 per patient per infection, depending on the nature of the surgery that they had in the first place. This amounts to a total cost of about £700 million a year. And that's all well and good, and it's important, but actually at the end of the day, there's a patient having an infection. It's not an infection, it's a patient with an infection. And me and my team did a little bit of work looking at the impact that infections have on patients. And they report that it's painful. It reduces their mobility, it stops them getting out of the house. They may end up having amputated limbs as a result. It has a significant emotional effect. They report being low in mood. There's significant psychological effects of having quite unsightly scars. And as I said, it stops them getting out of the house. They become isolated. They can't work. There's a financial burden associated with it as well. They spend longer in hospital. They come back to hospital. They go back into theatres for more operations, and they need complex wound management systems, which is a problem for both the patient and for us as clinicians. They spend lots of time on antibiotics, either tablet or intravenous. And again, that's a problem for us as clinicians, but also for the patient. When we spoke to patients, they said that one patient said that they could cry at the thought of having another cannula put back in because they'd had that many during the course of their infection. And ultimately, for us as clinicians, it can be a significant source of litigation. Wound dehiscence is slightly different from infection. So wound dehiscence is where a surgical wound opens up after it's been closed. It may be caused by infection, but it's not that all wounds that are infected dehisce and all wounds that are dehisced are infected. It is a significant complication and generally happens between 5 and 8 days after their operation, but can occur anywhere up to 30 days later. And if a wound is noted to be dehisced, then assessment for infection should be one of the first things that's done. And that's of the patient and the wound. That's all well and good. We can treat wound infections with antibiotics, so why are we that bothered about stopping them happening in the first place? If you haven't heard about antimicrobial resistance, then you've been living under a rock for the last 5 or 10 years. More and more infections now are being shown to be resistant to conventional antimicrobial treatments. And if you're not entirely sure what I mean by that, they adapt, they change the way that they respond to antibiotics, essentially making them useless. An infection can proliferate, and these resistant organisms can then spread to other people and infect more people, particularly in close-knit quarters such as a hospital. The World Health Organization have declared antimicrobial resistance a worldwide issue, and without effective antibiotics, antimicrobials, medical procedures that were previously routine become very high risk, such as organ transplants, major surgery such as caesarean sections or joint replacements, and patients who would otherwise be at risk of infection then become even further at risk, such as patients undergoing chemotherapy. Resistance now to first-line drugs for what we previously thought of as simple infections such as Staph aureus is becoming more and more common, and I'm sure you've all heard of MRSA, methicillin-resistant Staph aureus. Patients who have an MRSA infection are roughly 65% more likely to die of that infection than those who have a sensitive infection. A retrospective study of about 700 people in the UK that was published last year showed that more than 10 million operations were performed by the NHS in 2015 to 2016, but that we widely underreport the number of infections that these patients get. Whether that's because patients don't seek treatment for what could be classed as an infection, or that data is improperly or incompletely recorded, we're not entirely sure. But ultimately, we underreport the number of infections that patients have. Unhealed surgical wounds, according to this paper, account for about 10-11% of wounds that the NHS manage. And wound dehiscence following surgical procedures accounts for about 25 to 30% of all wounds that require continued nursing intervention, whether that's in hospital or in the community. To prevent surgical site infection, we have to drill down and look at what things can put a patient at an increased risk of surgical site infection. And this may be patient factors, exogenous factors such as the process and the procedure that they're undergoing, and the surgery itself. So things that patients can be or have that put them at an increased risk of surgical site infection include those with a compromised immune system, such as patients undergoing chemotherapy, patients who are colonised before they go into hospital with methicillin-resistant Staph aureus, MRSA, such as us, healthcare providers. We are in general colonised with MRSA. Diabetics, especially those with poorly controlled diabetes. Older patients, male patients are slightly more likely to have surgical site infection. Those that smoke are incredibly likely to get a surgical site infection. Poor nutrition, poor diet, obese patients, or patients that come into hospital with an infection, whether that's at the site of their operation or whether that's somewhere else, such as their chest or their urine. Then there's things that we do or don't do. So too much or too little antibiotic prophylaxis around their perioperative period. It's been shown that shaving of hair over an operative site can increase the risk of surgical site infection. Longer surgery increases the risk. Poor skin preparation, so that's the stuff that we slather on patients before we operate. Poor aseptic technique, and poor surgical team preparation, so hand hygiene. Operations that are carried out in an improper theatre environment, so all theatres should be well sterilised, well ventilated. Orthopaedic theatres should have laminar flow. The drapes and the surgical attire that's worn, and the technique of the operating surgeon. So good hemostasis and maintenance of a sterile field will reduce that risk of a surgical site infection. When you think of operations, or when we think of operations, we can classify them down into 4 categories. They can be clean operations, in which you're not expecting any contamination of the wound. They can be clean contaminated, where any contamination of the wound would be in a controlled fashion, such as a bowel resection that's undertaken electively. We are opening up the bowel, but we're doing it in a controlled fashion so that we should limit the amount of contamination to the wound itself and to the operative field. There's contaminated wounds, where at the outset of operation that wound is contaminated, such as if there is a knife wound to a hand or a stabbing. And then there's dirty wounds, where the wound is infected before we start, such as a peritonitis or an abscess. And the reason we classify like that is because it gives us an idea of how likely an infection is after the procedure. This is the bit that ultimately everyone needs to be aware of. If you take nothing else away from this, then take this away: is how you're going to pick up the patients with an infection before they become more unwell. Well, wounds might look a bit red, as this one does here. They might be slow to heal. They will probably be a little bit more painful for the patient. The wound itself will be tender, so if you press on it, the patient won't like you. It will be hot to touch. Bleeding isn't necessarily a sign of an infection. All wounds will bleed, but wounds that bleed and collect, given a hematoma, are more likely to get infected. And wounds might be swollen and tense. You might see pus coming out of that wound, and the wound might open up a little bit. And then systemically, the patient might be more unwell, so they might have a temperature. Their heart will beat faster, they'll be tachycardic. And if they're in hospital, or if you've got the facilities available to you, their blood results might become a little bit abnormal. So their white cells might go up and their CRP might go up. And ultimately, what you might find is that the patient has an abscess, so a collection of pus underneath or adjacent to that wound. So with all of that in mind and thinking about how rubbish it is for the patient to have an infection, how much of a financial problem it might be for the NHS should a patient get an infection, what we want to drill down to is how we can stop these patients getting surgical site infections. And there's 3 big bodies that have put out guidelines in the last 10 years. So the National Institute for Health and Care Excellence, NICE, have put out guidelines. The World Health Organization have put out worldwide guidelines for preventing surgical site infection. And the European Wound Management Association, EWMA, have either just put out or are in the process of putting out some guidelines for the prevention of surgical site infection. And ultimately, all 3 of those can be combined for us to look at how we can prevent those infections. So it requires an assessment of the patient as a whole, and not just by surgeons or nurses, but through a multidisciplinary approach. And also we need to manage the patient's expectations and educate patients on how they can help prevent their infection as well. We should be looking at things pre-operatively, intraoperatively and post-operatively, because all 3 of those are areas in which we can focus our attentions in order to reduce that risk of getting a surgical site infection. Pre-operatively, whether this is in a pre-operative clinic or on admission to hospital, or some things that the patient can do themselves, we should be looking for the patient's general health and any pre-morbid coexisting conditions that they might have. We should look at their sugar control. Are they a diabetic? Are they a well-controlled diabetic? We should look at their weight and how it's fluctuated recently. That might give us an indication of their nutrition status and how active they are. We should look at whether patients smoke, and if they do, we should attempt to help them to stop. And we should think about how long these patients are expected to stay in hospital, because we know that a longer hospital stay puts you at an increased risk of infection. Patients should be educated on the risk of an infection. When a patient comes into hospital for a procedure, they all sign a consent form, or they should, if they're able to. And most surgeons will put down infection as a risk on that consent form, but patients really need to take that on board and be educated on the steps that they can take to help reduce their risk of infection. And not only that, how to recognise develop an infection and who to speak to if they are concerned. They should also be given information on how they care for their wound, and what antibiotics they're going to have in the perioperative period and what that's doing for them. A lot of patients will have perioperative prophylactic antibiotics, but they may not understand the reasons that they have them. Patients should, so current evidence suggests that patients who shower either with soap and water or with something like chlorhexidine are at a reduced risk if they shower 24 hours before their operation. They should be informed that they shouldn't shave, that we as surgeons may carry out hair clipping but not shaving. They will go down to theatre in standard hospital pyjamas, garbs. In patients that are colonised with MRSA that's picked up on preoperative screening, they may be given nasal decontamination or skin decontamination. And in days gone by, it was common for patients undergoing bowel surgery to have bowel preparation, so high strength laxatives and antibiotics. But that's now been proven that it doesn't have much of an effect and is pretty inconvenient for the patient as well. We know that clean surgery, where we might leave something behind, such as a vascular prosthesis, a joint replacement, clean contaminated surgery and contaminated surgery, so those classifications that we talked about earlier, those patients should have antibiotic prophylaxis. So that's antibiotics given intravenously on induction, so when they're put to sleep, and then normally a couple of doses after their operation as well. In patients where the wound is dirty or infected, they should obviously be having antibiotic treatment already. Moving on to that intraoperative period now, obviously we as surgeons take great pride in how we decontaminate our hands and we wear sterile gloves and gowns. And for us in the UK, it sounds like it's fairly common sense, but remember that these World Health Organization guidelines are meant to cover a global audience. We use skin preparation to decontaminate the skin prior to incision, and the most effective at the minute, it seems, is chlorhexidine and alcohol. Incisions should be made first with the blade and then for the deeper layers with diathermy rather than diathermy all the way down. And as I said earlier, good surgical technique, so good hemostasis, good oxygenation of the patient, maintaining their temperature, tissue perfusion, will also reduce that surgical site infection risk. We shouldn't be using wound irrigation intraoperatively to prevent surgical site infection. And there's not a lot of evidence that suggests sloshing betadine on a wound before we close it is any better than not doing that. Once that wound is closed, we will all then go on and pop a dressing on. And there is a whole host of different products that are out there now which can be popped on a wound post-operatively, whether that's a film and a pad, an antimicrobial film and a pad, a foam dressing, negative pressure wound therapy, skin glue is used as a dressing. And if they're put on in an aseptic non-touch technique, after 48 hours, patients can be advised that they can then go ahead and shower that wound quite comfortably. Moving on to post-operative dressings, as we've been talking about, this is where my research interest comes in. I've been working for the last two or 3 years with a dressing called Leukoplast, which is a bacteria binding dressing which can help prevent surgical site infection through reducing critical colonization. Sorbact itself is a technology that's now included on a lot of different products. They are not bactericidal, they don't kill bacteria, they bind bacteria. There's not a chemically active agent that is ingressed into the wound. They work by something called hydrophobicity. So bacteria that can cause a problem are naturally hydrophobic, they repel water. Sorbact is very, very hydrophobic, so it repels water very, very strongly. And by that action, the hydrophobic dressing and the hydrophobic bacteria push water out from between them, and the bacteria is then bound to the dressing irreversibly. It's slightly different because there's been no evidence of resistance described or put out in the literature. It doesn't trigger endotoxin release from bacteria. There's not been any upper binding limit seen, and it's been shown to bind a wide variety of pathogenic organisms. And to date, there's been no evidence of systemic absorption or side effects or adverse effects that we know about. We, as I said, my team, have been looking at the evidence behind Sorbact technology and what's out there and what we've put out there as well. And to date, there are case studies, case series, observational studies, a randomized control trial or two, and a systematic review looking at its effectiveness. So going through a couple of those, there is a study by a team headed up by a guy called Mosty that was published in 2014 that compared silver containing hydrofiber dressing to Sorbact technology in chronic venous leg ulcers. This was a randomized single centre study looking at patients with hard to heal or localized infection leg ulcers. And it showed, they measured something called bacterial load, so how many bacteria were present on the surface. And it showed a reduction of 41.6% across both groups, but a reduction of almost 75% in the Sorbach group. Stanarowski, a team in Poland, conducted a randomized control trial looking at dialkyl alcohol chloride, which is the compound on Sorbach dressings, compared to standard dressings in adult women who've had a cesarean section. So a fairly clean procedure, a very common procedure. And this study was undertaken in Poland. They recruited 543 patients, and that they showed that using Sorbach technology reduced the infection rate from 5.2% to 1.8%. So that represents a 65% relative risk reduction, and that was statistically significant. One of the projects that I've worked on personally, we looked at Sorbach in vascular surgery. We took 100 patients who had a normal non-active wound dressing and then compared that to 100 patients who had their post-operative wounds dressed with Sorbach, and showed that in the early post-operative phase, so between 1 and 7 days, there was a significant reduction of surgical site infection, and by 30 days there was a reduction of 47%. We crunched the numbers and showed that we had to treat 12 patients with Sorbach to prevent 1 infection, which is a pretty small number needed to treat. Using the data from the Stanarowski trial, a team of very clever people in York have crunched the numbers and had a look at the cost effectiveness of Sorbach dressings. Now, they took the cost of surgical site infection per patient to be around £4,000. It's about £300 per day, purely an increased hospital length of stay, and an extra £120 per outpatient appointment. So taking all of those figures into account and looking at what the trial investigators in Poland found, that patients were discharged quicker, they had a better quality of life after, they recovered quicker, that using Sorbach technology could reduce the hospital length of stay for patients, reduce the number of outpatient appointments that patients needed, and reduce the need for treatment with antibiotics. And ultimately, when they applied it to patients in the trial, using Sorbach technology represented a saving of around £120 per patient, which highlighted a significant potential cost saving of around 50% over standard care. So in summary, surgical site infection is increasing and can be a big problem, and may prove to be an even bigger problem as time goes on. Combine the growing number of surgical site infections that we're seeing with the rise in antimicrobial resistance, threatens an even worse problem than we already have. There are new methods out there of reducing surgical site infection that warrant further investigation, with high quality research that's already been undertaken in the UK. SSI, for those who are interested, offer free education and training in surgical site infection and a whole host of other areas. And we're now going to move on to a real-time question and answer session. So moving on to our first question. First question comes from Michaela Goff. Do we know which operations end up with the most surgical site infections? Yes, we do, kind of. So we know which operations more commonly get surgical site infections, not necessarily end up with the most. So we know that vascular surgery puts you at an increased risk, and that's probably to do with the sort of patients that undergo vascular surgery. So they have poor circulation, quite a lot of them are diabetic, they smoke. So all of those risk factors that we talked about at the start come together in one patient with vascular surgery. So vascular surgery patients quite commonly get infection. Colorectal surgery is another area where patients get infections, and again that's because the bowel is breached and complications arising from that can quite often be catastrophic for the patient. So they are probably the main two. Vascular surgery and colorectal surgery are the two surgical specialties in which infection is most common. Not necessarily which operation they have, but the type of surgery that they have. Question 2 comes from Alison. Do you advise wound washouts prior to skin closure? No, at the minute, the current evidence suggests that there's no benefit to doing that. And I know a lot of people do, a lot of the surgeons that I work with do. They will irrigate a wound with betadine or chlorhexidine before the wound is closed. Actually, the current evidence suggests that a washout of a contaminated wound or a clean contaminated wound with saline is just as effective. Obviously, if a wound is dirty or infected or has been visibly contaminated during the procedure, then it makes sense to irrigate those wounds. But if it's a clean wound or a clean procedure, then the current evidence suggests that there's no real need to. Third question comes from someone who's nameless. Are the infections that we see in the community post-surgery accounted for in the statistics? Yes and no. As I said right at the beginning, what we know is that we underreport surgical site infections, and during one of the trials that I worked on and designed and ran, what we found is that there are two groups. There's a group of patients that come back into hospital because of their infection, and those do get accounted for. But there's quite a lot of patients who will be seen by their GP and managed with some oral antibiotics. It lasts for a week or so, it clears up, and although it's not particularly significant to us as clinicians, it can be significant to the patient, but ultimately that isn't always recorded unless we go back and ask for that information. So in some places that are conducting surveillance, I know teams in cardiothoracic surgery are very hot with surveillance, as is orthopedics. They can be, but quite a lot of specialties that don't carry out surveillance will miss these infections that come up in the community. Fourth question from Beverly. How can we help to engage patients more with regards to infections? For example, sometimes when we give advice, it's ignored. Tough one. Patients will always ignore our advice, but equally, all we can do is give the best advice that we've got. One of the pieces of work that I did was a focus group with some patients who had an infection. We asked all of them, were you aware of the risk of infection before you had your procedure? And without fail, they all said, well, I remember it being mentioned, but actually I wasn't really aware of the risk. And that goes with what you're saying. We do give advice, and whether that's surgeons, nurses, community nurses, GPs, all will give advice on what to do, what to spot, how to prevent an infection, but it sometimes falls on deaf ears. And that might be that we look at how we're delivering that information. Actually, if a patient comes into hospital, they get admitted the night before the procedure, they have all of their admission documents done, 4 or 5 different people will come and speak to them. It's very overwhelming for them. And it might be that we just have to time when we give them that advice a little bit better. So whether it's a couple of days before or at pre-assessment and they get written information that they can read through at their leisure and take in, maybe that's something that we should be looking at to help engage these patients. Question 5 comes from Karen. What are the benefits of irrigation with simple saline? Had this request twice recently without clear rationale. Hard to answer that question because I don't know where you are and whether you are in the community, in hospital as a ward nurse. Irrigating a closed, clean wound, probably not very beneficial. In irrigating a open, contaminated or dirty wound, probably more beneficial. I won't say more than that because, as I said, I'm not really sure where you are and from what angle you're asking that question, and I don't want to send you off in a direction without knowing a little bit more, if that's okay. Question from Joanne. As a practice nurse, some surgeons ask for daily packing of perianal incisions and drainage sites and some don't. What are your thoughts, as I feel daily can be too much and cause more problems? I'm not a colorectal surgeon, and I make no apologies for not being a colorectal surgeon. However, packing regimes will differ because there's not a lot of evidence for it at the minute, for how often we should pack, what we should be packing with, how the patient feels about packing. It will be patient dependent. Some patients will not like having a wound that's packed for a couple of days because it gets more painful, it gets smelly, it gets socially quite uncomfortable. There's a team, I think in Bristol, running a trial called PPAC that is looking at packing of perianal incisions. So I can't guarantee if and when it will be out, but work is being undertaken looking at that question, because the short answer is we don't quite know what is best. Question 7 from Emma. Would you recommend wound swabs when you suspect wound infection? Some consultants I work with don't rate wound swab results as there's already bacteria on the skin. Yes, swab it 100 times if you want. The more microbiological evidence you've got, the better. Yes, there is already bacteria on the skin. What you should be doing, particularly if a wound is open or is sloughy or has exudate on it, is cleaning that wound thoroughly and then swabbing. So you can irrigate it, you can lavage it with saline and then swab it, because if there is a positive swab after that, it suggests that that wound is either colonised or infected. Yes, I agree that if you swab a wound that hasn't been cleaned, there will be bacteria on the skin. But if you clean that wound down and then swab it and there's still positive microbiology, that will be a colonised or infected wound. Hope that helps. Question 8 from Rena. When do you think a post-op wound dressing should be changed? Again, it depends. You have to look at it on an individual basis. It might be that the dressing stays on for 2 days. It might be that it stays on for a week. Ultimately, if that wound dressing is soaked, if it's saturated, if it's full of slough, if it's hanging off, if the patient showered in it and it's macerated, then it should be changed. If it's visibly soiled, you could consider changing it. However, if it's still stuck, if it's not visibly soiled, if there's no evidence of infection or no concerns about the wound, then it can be left on. If the wound is happy and healthy and you're now 5 days down the line, the stitches are still in place, but the wound looks absolutely beautiful, then the dressing can be taken off and left off and the patient can shower comfortably. Question 9 from Nikki. Surgical site infection, Public Health England data collection is only mandatory for 3 months a year. Do you think it should be made mandatory all year round in order to have full picture of surgical site infection rates? Oh, wordy, very good question. I think yes, but I'm biased because most of my research is undertaken in surgical site infection, and it would help me and the teams that I work with and other teams in my situation massively if we had a countrywide picture of surgical site infection rates. It will also help surgical teams to look at what they are doing in their departments and how their rates vary through the year, how their rates vary by surgeon, and what they can do on a micro environmental basis or a local basis to change their own practices and hopefully improve their surgical site infection rates. Question 10 from Nikki. Why is cellulitis to the wound not classed as a surgical site infection? Let me clarify. Cellulitis around the wound is cellulitis close to, but not involving the wound isn't. So if you had a an incision in the groin and there was cellulitis of the lower leg, that's not classed as a surgical site infection, that's a simple cellulitis. If there is erythema and spreading infection away from the wound, that is. Cellulitis is just an infection of the skin in general, and by definition, if the skin has been breached by an incisional wound, then it's a surgical site infection. Sorry for that misunderstanding. Hopefully I've clarified that slightly better. Question from Alison: how long would Sorbact dressing remain in situ post-op? So we did a lot of work with Sorbact. We changed our dressings at day 2 because the theory is, obviously, as bacteria bind, when you take the dressing off, you take the bacteria away from the wound and pop them in the bin with the dressing. And we looked at day 2 dressing changes. What we know is that it can stay in place for up to 5 to 7 days. The pad and film is splash proof, it's very sticky, so it stays in place for 5 to 7 days. So as we were saying earlier about whether dressings are visibly soiled, whether they're peeling off, it's a little bit of a per patient individual basis, but they can stay in place for 5 to 7 days. What is your opinion on a negative pressure dressing immediately post-operatively? So I'm assuming you mean something like a PICO, single-use negative pressure device. I will wait to see the evidence. There is a lot of work being undertaken at the minute looking at single-use negative pressure. There's a group in the Northwest undertaking a trial called Sunshine, I think, Sunrise maybe, single-use negative pressure in colorectal surgery. There will hopefully soon be a group in the East looking at single-use negative pressure in vascular surgery wounds. The current evidence suggests that they may reduce surgical site infections, but there's not a lot of evidence out there, and there's not a lot of evidence to suggest they reduce surgical site infection any more than any of the other dressings that are on the market. And our last question, do you think a surgical site infection is a preventable mistake, or is it more a side effect of surgery? And if it was treated as a side effect, do you think there will be less resistance to report it? Very good question. I think it's perceived to be a preventable mistake. And we talk about reducing the risk, we talk about making it a never event, having a zero tolerance. So one of the Public Health England reports in the early 2010s called it taking a zero tolerance approach to surgical site infection. I don't believe that we will ever reduce the risk to zero. I think there will always be a risk of surgical site infection. I think in general, reporting should become more open, not only of surgical site infection, but of all complications, and that there should be less of a persecutory attitude to complications following surgery. And like you say, these should be looked at as effects rather than mistakes. Quite a thought-provoking one to finish with. This concludes our live training session. I'm sure there was loads more questions than I was able to answer. I apologise if I didn't get round to it. I'd like to just take this opportunity to give a little thanks to SSI for supporting this event. As we talked about, they've got a range of educational resources, and there'll be some contact details somewhere on your screen for you to go ahead and sign up for those if you want to. I hope that this has helped you gain a better understanding of surgical site infection, how it affects the patient, and what we can start doing to reduce those risks to the patients at the end of the day.